Good evening, all. Here we are, finishing up our last chapter, chapter 15, mental health treatment. I encourage you all to please work hard to do any assignments you didn't get done on time. Please try to get them caught up. Okay. Mental health treatment has a host of different angles to approach the treatment of mental disorders. Our last chapter was all about mental disorders. This chapter is about what we do about those. First of all, let's talk about the difference between different mental health providers. The first provider is a psychiatrist. Psychiatrists are MDs, medical doctors. They go to medical school and they specialize in the prescription of psychotropic medications, which we'll talk about. We will additionally talk about kind of the hierarchy of mental health professionals. The next down the list is a psychologist like myself. Psychologists usually do a lot of supervision as well as assessment and psychotherapy. Next down the rung is clinical social workers. I have a wife and son who are both clinical social workers who work with me in our practice. And I've known many clinical social workers who are extremely good psychotherapists. Clinical social workers can either go the direction of case management or psychotherapy. Of course, psychotherapy seems to be the best option, at least to me. Underneath clinical social workers come a host of different master's level psychotherapists who are trained in different aspects of counseling and advisement, just different ways of looking at the same problem. The higher you go up that scale, the higher the level of education and training that is also afforded. Actually, psychologists end up spending more time in school and training than do psychiatrists. Okay, let's talk a little bit about Hans Eysenck and psychotherapy outcome studies. Hans Eysenck helped psychotherapy remarkably. From the later 1800s to the mid-1900s, the 1950s, psychotherapy was discovering itself. And once at that place where psychotherapy thought it was doing a good job, Hans Eysenck gave psychotherapy a kick in the butt. And it was a good kick in the butt. If you'll remember, Eysenck was the psychologist who theorized that genetics were the most significant variable that contributed to personality development. Well, what he also was a good scientist. In his scientific work, he did a wonderful job of kind of eyeballing all of psychotherapy together. He went through a process where he took neurotic disorders, which in that day were referred to as depressive and anxiety disorders, or mood and anxiety disorders. And he took the 230 some odd most frequently referenced pieces of research at that time that supported good psychotherapy outcomes, and he eyeballed them. Now, today, we would use a statistical analysis called meta-analysis, where we're actually able to take numbers and do that eyeballing process that Eysenck did. But what Eysenck ended up determining with that whole eyeballing process was that these psychotherapies that were identified in these studies, most frequently referenced, did not do any better in their outcomes than the passage of time. Now, if you went to a therapist and the therapist said, well, we can give you therapy, but if you just wait for a while, you'll get just as much better as the therapy gets you. You wouldn't have much need to go into therapy. Well, Eysenck knew that that statement wasn't true. But what he was trying to do was put psychotherapy on task. And so new psychotherapeutic outcome studies were done over the next 20 years that were much better than the previous studies. Those previous studies were sloppy studies. And psychotherapy decided that it needed to improve its methodologies, and it did. And within 20 years, there was profound and undeniable evidence that psychotherapy makes a major difference in comparison to the passage of time. And since that time, in the mid-70s, psychotherapy has grown more and more and more to identify specific methodologies for specific individuals that are most likely to provide the greatest benefits for psychotherapeutic outcome. And Eysenck did a good job in doing that crucial criticism of psychotherapy. So we're going to divide our look at psychotherapeutic methods into three arenas: insight-oriented therapies, behavioral therapies, and biologically based therapies. The insight-oriented therapies, psychotherapies, are what you would normally expect to see if you were looking at a psychotherapist and what a psychotherapist does. So that's the therapist sitting in the chair, listening carefully, the person sitting on or even lying on the couch. I have a couch that people lie on if they want to sometimes. And that's kind of the classic look that people consider therapy being a part of. The behavioral therapies are really those specific therapies and extensions of the specific therapies that come from the theories of Pavlov and Skinner. And as you'll see when we get there and discuss them, you'll see the fingerprints of Pavlov and Skinner all over these things. I'm in the middle of a lecture, hon. Okay. Sorry about that. My poor wife just had her tonsils out. It is not an easy thing for people to have their tonsils out as adults. And then finally, we'll talk about biologically based treatments, which mostly is psychopharmacology, which medications. But we'll talk about some other things too, in addition to different types of medications. We'll start first by talking about psychoanalytic or dynamic psychotherapies, which they're most frequently called today. Freud, Jung, and Adler, and all of the permutations from that point on. Sigmund Freud, when he started doing his psychoanalysis, he initially was using hypnosis, but found that hypnosis was an artificial way of accessing the unconscious mind. And over a number of years, he decided to move away from hypnosis and instead use other methodologies to access the unconscious mind. These two major methodologies that were used by Freud and are still used today in psychoanalysis is dream analysis and free association. Now, dream analysis we've talked about a little bit back in chapter 5, so we're not going to talk about that much more. But a specific analytic method of dreams can access a great deal of information that people are not familiar with, but actually do appear to affect their behavior. Free association is a very interesting methodology. It's something that people have to learn to do. It's not easy to do. I will use it periodically with people if we have been working for a while and people are just coming in and kind of giving me a weekly travelogue of the week, and then they go and clearly they're not digging much deeper and we need to get deeper. So with free association, an individual either sits back or lies back and simply says everything and anything that comes to their mind. Now, when people do this, at first they're a little intimidated because think about it. Saying anything and everything that comes to your mind might even be a little embarrassing. But people find that they get past the embarrassment pretty quickly. And as they present that information and let their mind loosen, which then has the general purpose of opening up some unconscious material into the conscious mind, people actually feel remarkably relieved. And then we also end up with a great deal of fodder for the therapy canon also, because they've presented and identified some very helpful information. That's free association. Now, there are a number of things that have to happen in psychotherapy for it to be good psychoanalytic psychotherapy. 3 basic things: interpretation, resistance, and transference. I'd also add to that countertransference, and we'll talk about that a little bit too. Interpretation. A psychoanalytic therapist simply sits back and does a lot of listening, asks a few questions here and there, may make summary statements, may dig a little deeper into certain areas, but doesn't speak a whole lot. The idea is to let the patient take lead, take control, and move forward in this process. But after a while, after gathering lots of information, after listening to a great deal, then the psychoanalytic therapist simply gives an interpretation. Meaning, they kind of give a big summary of what the person's been saying for quite a few sessions along the way. And they can be pretty eye-opening and even sometimes disturbing or distressing revelations to people. They can accept them and try to work on them. Sometimes they will deny them and argue with them. And you certainly don't argue back. I mean, what good is that going to do? But often, then an individual will think on it and ponder it and usually come back and are willing to at least process some of those issues that have been interpreted for them. And interpretation is not a whimsical thing. It takes a lot of listening, a lot of analyzing, and a lot of evaluating, and then presented in a manner that hopefully is most likely that the individual will accept it and at least take a look at it. Second is resistance. Everyone has resistance to the therapeutic process. It doesn't matter who. Everyone will push back a little bit, as it were. An example of this was a woman who came to see me. She came in for the first 2, 3, 4 sessions, just kind of talked about general things, difficulties in interpersonal interactions in the home and such. And then she started to talk about abuse trauma within her family and eventually more deeply into her own childhood. And as she talked about this, I simply followed along, letting her take that lead, but had an active role in the process. After about 6 or 7 sessions, she started to kind of peter out. She'd forget about sessions, or she'd show up quite late, or other such things. And it was pretty clear that she was just pushing back against that psychotherapeutic process a bit. That was difficult for her, but eventually she just petered out, coming into treatment after 4 months or so of treatment. I usually, if someone just kind of quits coming, I let it go for a couple of weeks and then give them a call and ask what's going on. But for her, because of the dynamics of the trauma she had experienced, it felt to me like calling her and doing that would be pushing her. And pushing or potentially making someone feel controlled is not a good idea under those circumstances. And so I just waited. About 6 months later, she called me back. I think I ought to come back in. I said, okay, you can come back in. And it followed the same course. I did things a little differently this time. Instead of actively following along, I was more passive and sat back and let her guide it a little bit more individually. But ultimately, the same process occurred. She petered out over time, and that was the end of her process, at least that time. But I knew she'd be calling back again, so I waited. It was about 6 months later, and this time, when she called, said she thought she ought to get back in. I told her, yeah, I think you ought to get back in too, but we're going to have a little discussion before we get back into this again. And this time I kind of pointed out to her what she'd been doing. And it was a bit of a revelation to her, and it worked out quite well. She ended up accepting that and got to work and did some really good work and ended up doing quite well ultimately in the process. So that's kind of a classic example of resistance. But like I say, everyone exhibits a certain amount of resistance in the psychotherapeutic process. Finally, there's transference. Transference is a very interesting anomaly in psychoanalytic psychotherapy. Transference is all about patients taking their feelings that they have toward people in their real life and projecting those feelings onto the psychotherapist. Now, this is an interesting phenomenon because therapists don't share a whole bunch of stuff about themselves. Don't spend much time talking about the therapist or what the therapist thinks. Mostly it's about the patient and what's going on with the patient. And so these projections onto the therapist are a very clear indication that it doesn't have anything to do with the therapist. It has to do with what people are struggling with people in their real life. whether they're from the past, whether it's a deceased parent, whether it's someone they don't have anything to do with anymore, but you'll find that the patient will transfer those feelings and beliefs and propensities onto the therapist. And the therapist doesn't get all angry and say, that's not what I'm doing or being. They just simply process that with the person. And slowly the individual will work their way out of it and recognize that that's what they're doing. And then they're able to process through the issues with the therapist. There's also something called countertransference, and this is when a therapist kind of messes up and starts to transfer attributes of people in the therapist's real life onto the patient, and that's never a good idea. Therapists have to be very careful about this, and that's one of the reasons why we do a lot of supervision. We do a lot of talking about what goes on in our therapy sessions with colleagues, and we're able to sort out those kinds of things. Now, that's Freud's psychoanalytic psychotherapy. Carl Jung was a little different. He went even further into the depths of the subconscious mind than Freud did. Alfred Adler pulled back and to some extent desexualized, although he still believed very much in that sexualization concept. But Adler tried to apply more commonsensical approaches than did Freud, and especially than did Jung. Interesting ideas. So hopefully that gives you a little picture into what a psychoanalytic process would look like. The second therapy is called person-centered therapy, and this is Carl Rogers. Carl Rogers, as you remember, was a humanist. Now remember, a psychoanalytic therapist believes in those three basic principles: the unconscious mind and accessing that unconscious mind and structures in the unconscious mind. Helping people recognize how they may have gotten stuck in different stages of psychosexual development. And then working through defense mechanisms to help them get there. And it's the belief that there are deeply what appear to be negative motivations in the unconscious mind that need to be worked through. Now, on the other hand, person-centered therapy by Carl Rogers is a humanistic therapy. And remember, humanistic therapy believes that the core of every person is good, and second, that we all have choice, and we can choose our way out of our work. Now, what does the psychotherapy look like for person-centered therapy? Most therapists know how to do some Rogerian psychotherapy. It's a good way to begin a psychotherapeutic process, and then you may be able to modify slowly and mold into a different type of treatment process if you'd like. But it's always a good idea to start with a good psychotherapeutic technique, like person-centered therapy. There's a mirroring process that goes on. Now, as we mentioned, psychoanalytic, psychodynamic therapies are relatively quiet on the part of the psychotherapist, sitting back, listening, commenting here and there, asking questions here and there, but mostly just listening. Whereas Carl Rogers says that psychotherapy needs to be incredibly active. where you were constantly active in the therapy. That whenever he called them clients, would explain something, the therapist would always mirror back what was being said, with a little bit of realistic reaction to what the client would say, which in essence gives the client the opportunity to look at what they're saying and decide whether or not that's what they really mean. And if they do, they often then feel validated and they continue on because they feel an affinity and a desire to move forward with that. On the other hand, if it's not really accurate, they realize, well, that is what I said, but that's not completely what I really mean. Actually, and then they continue on going deeper into what was actually being meant. Now, this mirroring process and the back and forth between the therapist and the client does a couple of things. First of all, what's really trying to be done here has to do with two terms that you've learned about before with Rogers, and that is the self and incongruence. Now, what is the self in humanistic therapy? The self is who we perceive ourselves to be, and even more deeply, who we really are, deeper and underneath all of those layers of life that have kind of covered up parts of us that we slowly have to go into and peel off those layers of life process. And the issue here is that people will experience, as they try to talk about who they are and what they're going through and what they're dealing with, they will experience moments of incongruence where their cognitions and their emotions and their behavior don't necessarily match up. And when that matchup doesn't occur very well, then we've got this feeling of not fitting, and people like to have things fit. That's incongruence, and that incongruence motivates us to move forward in the psychotherapeutic process and do more and talk more deeply. I'm going to share on the lectures another feed, a YouTube channel that shows 3 of the master psychotherapists at work, all working with the same personality disordered woman. This woman's name is Gloria, and she has a dependent personality disorder. It's very interesting to watch. You have to watch carefully, and you have to kind of watch for the subtle things that she does that show very clearly that she exhibits those dependent personality styles, especially with Rogers. But it's Carl Rogers, who is a humanist, Albert Ellis, who is a cognitive behaviorist, and Fritz Perls, who's a Gestalt psychologist. And each one of them spend a therapy session with Gloria. So I will send you the, I'll put on the lecture section on chapter 15, that third feed, so that you can take a look at it if you'd like to. It's actually very intriguing to watch. And it might also help you to recognize the magnificent differences between psychotherapeutic techniques, and yet all 3 of them seem to have very positive impacts in their own way. But Carl Rogers is just wonderful as he's working with her, trying to help her resolve some of the incongruence she feels by giving back to her what she keeps saying to him. so that she gets to look at it. Now, in person-centered therapy, the therapist has to provide three basic things. The first is empathy. Now, none of us can be absolutely perfectly empathetic. We would love to be, but there's no way we can be perfectly empathetic with anyone because we can't crawl into anybody else's skin. But we can sure try really, really hard. And the harder we work at being empathetic with the people we work with, the better we help them take a deeper look into themselves. Second is unconditional positive regard. Unconditional positive regard means we have to find value in that person. Some therapists, when they have difficulty finding that regard for the person they're working with, will ultimately suggest that the individual go try out a different therapist because they're not really doing them much good if they can't have that kind of regard for people. I haven't worked with many people that I've had difficulty with that way. But every once in a while, when somebody really, really gets on my nerves, I find that it's usually something about me that's getting in the way of me being able to do that for them. And if I dig deep enough inside myself, I kind of recognize that I'm able to resolve that. And then we're able to do some better work with the patient. And the third characteristic that the therapist needs to provide is genuineness. A therapist has to be exactly who the therapist is. There can't be a therapist persona and another persona. It has to be exactly who that therapist is. And I am the same sarcastic, joking, fun, and yet serious and deeply concerned individual in everyday life that I am in the therapy office. I will supervise sometimes young therapists who need supervision before they can get licensure. And when I do that, I usually just have them come in and run a group with me. It's the best way to see their therapy skills, and we just work it out together. And one of the things that most young therapists have to learn is how to be themselves. The way you be yourself has to be a reflection of how you take the therapeutic techniques and apply them in a way that is unique to you as a therapist. It's extremely important. So that's person-centered therapy. And again, I hope you'll take an opportunity to look at Carl Rogers and watch how he works with Gloria in this regard. There's cognitive therapy. Cognitive therapy started out as a therapy all on its own. It didn't end up being a sole therapy on its own, but combined with behavioral therapy. And we now call it cognitive behavioral therapy because it seems that the way we think and the way we behave can't very accurately be separated from each other. But the cognitive process is a very, very interesting process. Cognitive therapy has to do with the idea that both our emotions and our behavior are consequences of the things we believe, our belief systems. So, Aaron Beck is a very well-known cognitive therapist. He wrote the book that every good psychotherapist has on their shelf called Cognitive Behavioral Therapy for Depression. One of the methods that he uses is a very interesting method. It's called cognitive restructuring. So let me give you an example of this. Okay, I was working with a woman who had been an NCAA athlete. She was a very good NCAA athlete. She came to see me for a number of different reasons, but one of those reasons was to try to figure out why she got stuck in certain situations. Well, at least stuck emotionally. Well, whenever she would, as a kid and a teenager, win something in her sport, her father would ask her, well, why didn't you set the school record? And when she did set the school record, he'd ask her, well, why didn't you set the district record? And when she set the district record, he asked, well, why didn't you set the state record? Which she did all of them eventually. She was a very good athlete. And you might think that was cruel. Well, the father wasn't a bad guy. He was just trying to motivate her and doing the best he could. But that kind of leaves a person always striving and never achieving, at least in their mind. So she worked for an advertising agency. She was preparing a layout for, I don't know, a newspaper or a magazine, something. And she had it all set up on her computer. And then that computer, she had everything laid out. I don't know how these artists do it with their juxtaposing and contrasting and all that stuff. And she was about done, and the office had a big open concept, so everybody's desks were out in the middle of everything. And her boss went walking by and looked at her screen and stopped and came up and just gushed with positives toward her. Told her that, how she'd contrasted this with that and juxtaposed that with this had been so unique, and it had done a really wonderful job of opening up a new way of looking at the product or whatever it was they were selling, and told her how incredibly pleased the client's going to be, and this was really great, and then went to walk away but stopped for a moment and then pointed down in the corner of the screen and said, this little thing right here in the corner of the screen, I found that if you just do this rather than that, it just makes the whole thing a lot easier. Just a trick of the trade I've learned. And then he went on to praise her even more for how well she'd done. Well, she came into therapy that day. And when she came in, she was pissed. She was so mad. I asked her, well, why are you so mad? It sounds like he praised you a lot. She was so mad. She almost deleted the entire thing just because of that comment down in the corner of the screen. Well, I said, okay, let's do a little exercise here. And what I did with her was cognitive restructuring. So I said, okay, when this situation happened, how did you feel? She said, I was pissed. And I said, I know, but anger is usually a secondary emotion. It covers up and protects us from more tender emotions. She said, well, I guess I was hurt and I was disappointed. I said, okay, on a scale of 0 to 100, how hurt and disappointed were you? And she said, it was an 80. And it even surprised her that she said 80. And I said, okay, that's all right. And I explained to her that we all have these beliefs that we carry around in our heads, and we all do. I don't care who you are, we all have them. They're these negative beliefs that we have about ourselves. And they're lies. They're absolute lies. But we believe them. And I said to her, so I want you to focus on that hurt and that disappointment. And I want you to finish the phrase, I am blank. And it's a simple phrase because these things come from childhood. So she thought for a moment. She said, I am never good enough. I said, okay. Now, from the description that I gave you, you can understand why she felt like she was never good enough. I said, how strong, on a scale of 0 to 100, did you believe in that moment, I am never good enough? And she thought for a moment and said, an 85. And again, it surprised her. And I said, okay, now we know what the problem is. The problem is you've got a lie. And you carry that lie around with you, and you don't even recognize it most of the time. It's just always there. She thought for a moment, thought that sounded like it was probably correct. I said, okay, let's fix it. So I said, okay, I want you to tell me one thing you've done in your life that absolutely contradicts I am never good enough. And what she said was, well, I was an NCAA All-American. And that's a pretty big deal. But even more important to me is I was an academic NCAA All-American. The number of hours I had to put in every day for my sport was just incredibly high. And the fact that I had as high a GPA as I did, that made me an academic All-American, that really meant something to me because every bit of blood, sweat, and tears that I put in there earned me that. I said, okay, great. And I said, well, how strongly do you believe I am an NCAA academic All-American? And she said, well, 100%. I said, good. Then I asked her, I want you to tell me one thing about you, just one thing you know about you that contradicts I am never good enough. And she thought for a little bit. Then she said, I'm a good mom. She had 2 little boys. And I said, well, how much do you believe that? And she went to say, because she was going to say 100. And then she stopped herself and she said, well, 95. I said, okay, 95's pretty darn good. And at that point, I said to her, okay, I want you to take that belief that you're an NCAA All-American, or academic NCAA All-American of 100, and you're a good mom of 95, and I want you to hold it up against that 85 of I am never good enough. And I want you to tell me what happens to that 85 when you do that. And you could just see her whole countenance just drop. It was just like, this relief. She said, it just almost goes away. And I said, well, give it a number. She thought for a minute. She said, well, it goes to like a 25. I said, great. I'll take a 60-point drop any day. And then I said, now that that belief has dropped down to a 25, what happens to that hurt and disappointment of 80? She said, that drops too. I said, well, what does it drop down to? She said, a 20. I said, great. Can you handle a 25 and a 20? She said, I can handle a 25 and a 20 all day long. So it was simple use of cognitive therapy, identifying what Aaron Beck called the, oh goodness, I'm forgetting the term. This is an Alzheimer's moment. It'll come to me in a minute. But this belief, identifying it and then confronting it with truth so that it changes. Now understand, it doesn't just change everything all of a sudden. You have to keep working at it. You have to keep doing this process over and over and over again in your head. And it really does make a difference. Finally, today, let's talk a little bit about group therapy. Why is group therapy sometimes better than individual therapy? Well, people always say things like, well, you feel validated. You feel like people um, understand you, and there's a camaraderie, and you don't feel alone any longer. And all of those things are true, and it does help. Because in a very real way, you can't kid a kidder. Everybody in the group is dealing with the same issue. And if they're all dealing with the same issue, then you really can't pull the wool over anybody's eyes, as it were. But in addition to that, there are some very more business-like issues that make group therapy better. You treat a whole bunch of people for a whole lot less money per person. Now, as Irving Yalom, who's kind of the master of group therapies in the psychotherapy world, he says that it takes somewhere between 8 to 12 group sessions before people really start trusting each other and then doing work. But once they do, it's an amazing experience. The therapist just kind of guides. Have you ever seen an ox cart driver? They walk along the side of the oxen, and they have a stick. And they don't smack the ox with the stick, not at all. All they do every once in a while is just tap the oxen on the shoulder. And if they tap the oxen on the shoulder in one place, it means go to the left a little bit. Or if they tap it another place on the shoulder, it means go to the right a little bit. And the ox knows this. And the ox cart driver and the ox, they have a pretty good relationship in that regard. And that's what a good group therapist does. They just nudge here and there, here and there, just to get to that therapeutic place where people can do some magnificent work and change in the group therapy process. So, that's the end of today. Tomorrow, I will put on the next lecture, and that lecture is going to include behavioral therapies and the biologically based therapies. And then we are done with all of our lectures. Hopefully you're all working very hard to get done. I hope you are. I am invested in y'all doing well, and we'll get through this quarter together. Okay, good to talk to y'all. Bye-bye now.